Dr. Alan Hayes grabbed the chart right out of Sarah Walker's hands. In front of every nurse, every orderly, every single person standing in that hallway, he looked her dead in the eye and said, "Go back to med school, sweetheart. Real soldiers don't die waiting for a little girl to figure out which end of the scalpel cuts." The laughter that followed was slow, cruel, and deliberate. Sarah's face went still. Not because she was afraid, but because she had heard that kind of laugh before, and she had made a promise to herself the last time she heard it. She was never going to walk away from it again. If you are watching this right now, please subscribe to our channel and follow this story all the way to the end. Drop a comment and tell me what city you are watching from. I want to see just how far this story travels. The morning Sarah Walker reported for her first shift at Landstuhl Regional Medical Center, the sky over Germany was the color of old steel. Not dramatic, not cinematic, just gray and cold and indifferent. The way mornings tend to be when something important is about to happen, and the world hasn't gotten the memo yet. She had driven herself to the base in a rental car she could barely afford, with a duffel bag in the back seat and a thermos of coffee that had gone lukewarm somewhere around the checkpoint. She was 31 years old. She had finished her trauma surgery residency at Johns Hopkins, completed a fellowship in battlefield medicine at Walter Reed, and spent 14 months embedded with a forward surgical team in a classified support role that her discharge papers described only as medical advisory. She was not new to war. She was not new to blood. What she was new to was this hospital, these people, and the particular brand of cruelty that comes packaged inside institutional arrogance. She walked through the front doors at 6:47 in the morning. The day shift had just come on. The hallways smelled like antiseptic and burnt coffee, and the faint metallic edge that trauma hospitals always carry, that smell that gets into your clothes and stays there, no matter how many times you wash them. The charge nurse at the front desk, a woman named Corporal Rita Sosa, looked up from her clipboard and gave Sarah the kind of once-over that said she had seen 100 new doctors walk through that door, and she had watched most of them either prove themselves or fall apart within the first 72 hours. "Dr. Walker?" Rita said, not unfriendly, just efficient. "You're early." "I'm always early," Sarah said. Rita nodded once, like that was an acceptable answer, and handed her a badge and a locker assignment and a stack of intake forms that needed to be signed before she could touch a patient. Sarah was signing the third form when she heard him. She didn't know it was Hayes yet. She just heard the voice, loud, carrying. The kind of voice that had learned long ago that volume was authority, that filling up a room with sound was the same thing as owning it. "Where is she?" the voice said. "Where is our new addition, the prodigy they shipped in from stateside?" There was laughter, more than one person. The kind of laughter that is not about something funny, but about something social, about belonging to the group that is doing the laughing instead of the group being laughed at. She turned around. Dr. Alan Hayes was 54 years old, 6'2", and built like a man who had once been athletic and had simply never stopped being physically imposing, even as the muscle softened slightly at the edges. He had gray at his temples and deep lines around his mouth and eyes that had seen more than they were ever meant to see, and he carried all of it without apology. He was flanked by 2 residents and a senior nurse who had the uncomfortable expression of someone who had decided long ago that laughing at the boss's jokes was simply the cost of keeping a job. He looked at Sarah the way you look at something you are not sure belongs in the room. "Dr. Walker," he said, drawing the name out slowly. "Sarah Walker, Johns Hopkins, Walter Reed, Forward Surgical Advisory." He said advisory the way some people say assistant, like the job is almost a real job, but not quite. Impressive resume for someone who looks like she graduated last Tuesday. Sarah set down her pen. She looked at him. "Dr. Hayes," she said, "I've read your published work on hemorrhagic shock protocols. Your 2019 paper on tourniquet application in non-ideal field conditions was cited in the training materials at Walter Reed. It's good work. She paused just long enough for the compliment to land. I'm looking forward to learning from the team. Hayes blinked. Just once. Like he had been expecting either pushback or fawning, and had gotten neither, and didn't quite know what to do with it. Then the corner of his mouth turned up, but it wasn't warmth. It was something else. Well, he said, we'll see about that. He walked away. The residents followed. The nurse gave Sarah a look that lasted exactly half a second, but contained an entire conversation inside it. Something like, he does this to everyone. Something like, don't let it get to you. Something like, he broke the last one. Sarah picked up her pen and finished signing the forms. Her first patient was a 23-year-old Army Ranger named Specialist Marcus Webb, who had come in overnight with a penetrating abdominal wound from a training accident that had gone wrong in ways the report was deliberately vague about. He had been stabilized in the ER and was waiting for a surgical consult to determine whether the initial repair was holding or whether he needed to go back in. Sarah read his chart in the hallway before she went in. She read it twice. Then she went in and introduced herself and sat down next to his bed instead of standing over it, which made him blink in mild surprise. How's the pain? She asked. Managed, he said, which was soldier for terrible, but I'm not going to say so. On a scale of 1 to 10, she said, with 10 being you would rather be anywhere else on earth right now. He almost smiled. 7.5, he said. Okay, she said. Honest, I appreciate that. Let me take a look at what we're working with. She was midway through her examination when Hayes appeared in the doorway with one of the residents, a young man named Dr. Priya Kapoor, who had the exhausted eyes of someone in their second year and the careful posture of someone who had learned to be invisible whenever Hayes was nearby. Anything interesting? Hayes said, not to Webb, not really to anyone, just filling space with his voice the way he apparently did everywhere he went. Possible re-bleed at the repair site, Sarah said without turning around. I want to order an imaging follow-up before I clear him. Hayes made a sound in his throat. Not agreement, not disagreement, something in between that was designed to make her feel uncertain about her assessment. The overnight team already cleared the imaging, he said. It's fine. The overnight imaging was taken 4 hours ago, Sarah said. If there's a slow bleed at the repair margin, it might not have been visible yet. Hayes looked at her for a long moment. Then he looked at Kapoor. Eager, he said, like it was a diagnosis. Write it up, he told Sarah, and I'll review it. He walked out. Kapoor lingered for exactly 2 seconds. He glanced at Sarah with an expression she couldn't fully read, something caught between admiration and warning. Then he followed Hayes down the hallway. Sarah turned back to Webb. He was watching her with the careful attention of someone who had learned to read rooms. He always like that? She asked. Pretty much, Webb said. He's good, though, he added, like he felt obligated to say it. I know, Sarah said. Good and kind aren't the same thing. She ordered the imaging. It came back 2 hours later showing exactly what she had suspected. A hairline compromise at the repair margin. Not immediately life-threatening, but a slow problem building toward a fast catastrophe if it was left alone. She paged Hayes. He reviewed the imaging in approximately 90 seconds and said nothing to her directly, but ordered the follow-up procedure through Kapoor, who relayed the instructions to Sarah with the careful neutrality of someone delivering a message they weren't sure how to feel about. Sarah did the procedure. Clean, efficient, no complications. She was scrubbing out when she overheard Hayes in the next bay, talking to 2 of the senior nurses with the casual assumption of a man who doesn't check whether he's being overheard because he doesn't particularly care. She got lucky, he said, fishing for problems to solve. Classic new blood behavior. Show off, step on toes, hope it works out. The imaging did show a rebleed, one of the nurses said carefully. Could have been a coincidence, Hayes said, or confirmation bias. She expected to find something, so she interpreted a borderline image as pathology. There was a pause. Either way, he said, keep an eye on her. I don't want cowboys in my OR. Sarah stood at the scrub sink with the water running over her hands and counted to 10. She had learned to count to 10 at 22 during her first surgical rotation, when an attending had told her in front of a gallery of observers that her suture technique was what you'd expect from someone who learned medicine from YouTube videos. She had counted to 10 then. She had gone home and practiced her suture technique for 6 hours straight on a synthetic tissue pad, and she had come back the next morning and she had been flawless. Counting to 10 was not about calming down. It was about converting heat into fuel. By noon, the hospital was beginning to receive the first of what would become a flood. The call came through the command channel at 11:48. A large-scale engagement had occurred approximately 80 kilometers from the base. Details were classified and would remain so, but the medical implications were immediate and non-negotiable. Casualties incoming, multiple trauma cases, ETA 30 to 40 minutes for the first transport. The shift changed in character the way weather changes, not gradually but all at once. The managed hum of routine became something faster and tighter and more alive with controlled urgency. Sarah had seen this before. She had felt it before. That specific sharpening of the air when the work becomes real in a way that routine work never quite is. She was already moving, pulling on gloves, reviewing the pre-positioned protocols for the trauma bays, when Hayes called the team together in the main corridor. He stood at the center of the hallway like he had been standing at the center of things his whole life, which was probably not far from the truth. He ran through assignments with the practiced efficiency of someone who had done this enough times that the doing of it was almost automatic. Kapoor on Bay 2, Senior Nurse Delgado on Bay 4, anesthesiology on standby in all active bays. Then he looked at Sarah. Walker, he said, triage support. You assist where I direct you. You do not make independent surgical decisions without running them through me first. Clear? Clear, she said. Exactly that word. Nothing more. He held her gaze for one beat longer than necessary. Then he moved on. The first transport landed at 12:19. 3 casualties, 2 stable, 1 critical. Sarah was in triage when they came through the doors. The critical patient was a staff sergeant named Torres, 28 years old, bilateral leg trauma, suspected vascular compromise in the right lower extremity. The paramedic team was calling out vitals in the flat, focused cadence of people managing controlled chaos, and Sarah was already moving alongside the gurney, reading the field notes, her hands moving over the assessment points in the sequence she had practiced so many thousands of times that her hands knew what they were doing even before her brain fully caught up. Dorsalis pedis is absent on the right, she said to Kapoor, who was running the bay. We need a vascular surgery consult right now, and I want imaging on that right leg before we do anything else. Kapoor was already reaching for the consult request when Hayes stepped into the bay. I've got this one, he said, not to Kapoor, not to Sarah, just announcing it to the room. He reviewed the field notes. He examined Torres. He was fast. He was thorough. He was very, very good at what he did. And Sarah was not going to pretend otherwise just because she didn't like him. Prep for fasciotomy, he told the room. Possible compartment syndrome. We move in 20 minutes. Sarah said nothing. She moved to the supply prep position and began laying out the fasciotomy kit with the quiet efficiency of someone who knew where every instrument went and why. Hayes glanced at her. Just once. She was already done. The second wave came in at 1:43. 4 more casualties, 2 of them simultaneous critical. Hayes took one. He put Kapoor on the other with Sarah assisting, which she understood to mean, let the resident take the lead and you hold his hand and do not step in front of him unless the patient is about to die. Kapoor was good, young and a little unsure of himself in the way that second-year residents are unsure of themselves. Not from lack of skill, but from lack of the specific, deep confidence that only comes from having made the difficult call alone and having it go right. He was managing a thoracic cavity injury, controlled, methodical, and then he hit a complication that the initial imaging hadn't flagged, an unexpected hemorrhage point near the pulmonary hilum, and for approximately 4 seconds, he froze. 4 seconds is not very long in ordinary time. In an OR, it is an ocean. Sarah didn't push him aside. She didn't take over. She leaned in, close enough that only he could hear her, and she said, "Clip the bleeder at 9 o'clock from your current position. Don't think about the hilum. Think about the bleeder. One thing at a time." Kapoor breathed. He moved. He clipped the bleeder. His hands steadied. He finished the procedure. The patient's blood pressure came back up within 90 seconds. Kapoor stepped back from the table afterward and let out a breath that contained approximately 6 months of accumulated stress in it. He looked at Sarah. She was already turning to check the instrument count. "Thank you," he said, quietly, across the room. "You did the work," she said. She meant it. Hayes had seen it from the adjacent bay. Sarah knew he had seen it because she saw the exact moment his attention shifted from his own patient to hers. That particular quality of stillness that people have when they are watching something they did not expect to see. She didn't look at him. She didn't need to. By 3 in the afternoon, the team had processed 9 casualties. By 4:30, it was 14. The hospital was running at capacity, and the incoming reports suggested there would be more before the day was over. The staff had been on their feet for hours, and the particular kind of exhaustion that comes not from lack of sleep, but from sustained high-stakes concentration was beginning to show in the quieter, shorter way people were talking to each other, the way small irritations became large ones, the way jokes got darker and shorter. Sarah had not sat down since noon. She had not eaten. She had drunk approximately 32 ounces of water from a bottle she kept in her coat pocket and refilled whenever she passed a drinking fountain, which was a habit she had developed in the field, where forgetting to hydrate during a long casualty surge was the kind of small mistake that turned into a large one by hour 9. She was standing at the central monitoring station, reviewing the most recent set of vitals across the active bays, when Hayes appeared beside her. He didn't say anything for a moment. He just looked at the same screen she was looking at. Then he said, "Webs rebleed." Just those 3 words. "You were right about it," he said, still not looking at her, still looking at the screen. "I know," she said. He made that sound in his throat again. This time it was different, not dismissive, something harder to identify, something that sounded, if she was reading it correctly, almost like the beginning of recalibration. "The Kapoor consult," he said. "You talked him through the hilum complication." "He was about to get there himself," she said. "No, he wasn't," Hayes said. He finally looked at her. "He was 4 seconds from calling for an attending." "But he got there," she said, "and next time he'll remember that he did." Hayes looked at her for a long, unreadable moment. Then he looked back at the screen. "Don't read too much into this," he said, "but you can run Bay 3 independently for the next surge." It was not an apology. It was not respect. Not yet. Not fully. It was something more like a door opening by exactly 1 inch. Sarah looked at the screen. "Understood," she said. The next surge came at 5:17, and it brought with it something that nobody in that hospital was prepared for. Not the volume of it, though the volume was significant. Not the severity of it, though 2 of the incoming cases were among the most complex trauma presentations Sarah had seen outside of a classified forward position. What nobody was prepared for was who was coming in with it. The call came through the command channel at 5:14, 3 minutes before the first transport touched down, and the voice on the channel was clipped and precise and carried in it a particular quality of urgency that made every person in earshot go very still. "Incoming, critical. 1 patient, priority 1. Identity classified until arrival. All department heads to Trauma Bay 1. This is not a drill." Hayes moved toward Bay 1 without running, because Hayes was not the kind of man who ran in hallways. but he moved with a velocity that communicated exactly what running would have communicated. Kapoor was right behind him. Delgado was behind Kapoor. Sarah was last through the bay doors, not because she was slow, but because she had paused at the monitoring station for exactly 4 seconds to pull the backup trauma protocol for priority 1 cases onto the tablet she carried. 4 seconds. And in those 4 seconds, she had read the 3 lines of pre-arrival medical data that had come through on the secure channel ahead of the transport. She had read those 3 lines, and something in the back of her mind had gone very, very quiet. She walked into Bay 1. Hayes was already at the head of the incoming gurney position, gloved, ready, running through the incoming field report with a charge medic on the transport line. Kapoor was at his shoulder. The rest of the team was positioned around the bay with the practiced geometry of a trauma team that had worked together for years. Sarah found her position. She opened the tablet. She looked at the 3 lines of pre-arrival data again, and she said, quietly but clearly, to no one and to everyone, "If these vitals are accurate, the standard hemorrhagic shock protocol is going to kill him." The bay went quiet. Hayes turned and looked at her. His expression was not angry. It was something more complicated than angry. It was the expression of a man who has been doing something one way for a long time and has just heard someone suggest that the way might be wrong, and who is intelligent enough to know that the suggestion might be worth hearing and experienced enough to resent that it is coming from where it is coming from. "Explain," he said. 1 word. The whole room was listening. Sarah looked at the tablet. She looked at Hayes. She said, "The field notes indicate a traumatic brain injury component concurrent with the thoracic trauma. Standard hemorrhagic shock resuscitation is going to push his intracranial pressure past the threshold before we can get him stable. We need a modified protocol, lower target blood pressure, earlier hyperosmolar therapy, and we need neurosurgery in this bay before the patient arrives, not after." Hayes was already thinking. She could see it. The thing about Hayes, whatever else he was not stupid, and he was not so proud that he could not hear a correct argument when one was being made. But he was also 54 years old, and he had been doing this for a long time, and the weight of all that experience was pressing against the instinct to defer to it. "That protocol is not standard here," he said. "No," she said. "I developed it with a forward surgical team in a classified support role. It has a documented success rate of 81% in concurrent TBI and thoracic trauma cases in high-altitude engagement zones." Hayes stared at her. "Documented where?" "In a report that is currently sitting in a classified file at Walter Reed," she said. "I can have the unclassified summary to you in 20 minutes. Or you can trust me right now, and we can discuss the paperwork after." The transport doors at the end of the hall opened. Hayes made his decision in approximately 2 seconds. He turned to the room. "Modified protocol," he said. "Walker is directing the TBI management track. Kapoor, you're with me on the thoracic component. Delgado, get neurosurgery on the line right now. Tell them we need someone physical in this bay in the next 4 minutes." The team moved, Sarah moved, and the gurney came through the doors. The man on it was 61 years old. He was in full combat fatigues, with the insignia partially obscured by field dressing. His face was gray-white with a particular pallor of significant blood loss, and his eyes were half open in the specific unfocused way that indicated either severe pain medication or a declining level of consciousness. And the monitoring equipment attached to him was singing a complicated song of numbers that confirmed everything those 3 lines of pre-arrival data had suggested. It was not until the charge medic handed Hayes the official classified identification sheet that Hayes looked at it and then looked up at the room with an expression that Sarah had never seen on his face before. Something that was not quite shock, because Hayes was not a man who shocked easily, but something adjacent to it. Something like weight. Like the weight of the next several hours suddenly becoming very specific and very heavy. He handed the sheet to Kapoor without a word. Kapoor read it. He looked at Sarah. He looked back at Hayes. Then he handed the sheet to Sarah. She read the name. She looked at the man on the gurney. She looked at the numbers on the monitoring equipment. She looked at Hayes. "Ready?" she said. Hayes looked at her for one long, absolutely still moment. And then he said something that she would think about for a very long time afterward. He said, "Don't make me regret this." Sarah looked at the patient. She pulled on her second glove. "I never do," she said, and they went to work. The man on the gurney had a name that changed everything in that room, and Sarah Walker was the only one acting like it didn't. That was the thing Hayes noticed first. Not her technique, not her speed, though both were immediate and precise. It was her face. Every other person in Bay 1 had registered the name on that identification sheet and had shifted, subtly, in the way people shift when the stakes become personal and institutional and political all at once. Kapoor's jaw had tightened. Delgado had inhaled sharply through her nose. Two of the nurses had exchanged a glance that lasted exactly half a second and contained inside it the full weight of what it meant to have a 4-star Marine general bleeding out on your table. Sarah had read the name, looked at the patient, looked at the monitors, and started working. That was all. Like the name was information, just information. Hayes filed that away somewhere and focused on the thoracic component and tried not to think about the fact that he had just handed control of the TBI management track to a doctor he had known for less than 12 hours. The general's name was James Donovan. 4 stars, 38 years of service, the kind of man whose photograph appeared in congressional briefing rooms and whose decisions had moved people and resources across entire theaters of operation. He was also, right now, a 61-year-old man with a significant intracranial bleed, a compromised thoracic cavity, a blood pressure that was trending in the wrong direction, and approximately 6 minutes of margin before the window for intervention began to close in ways that would become irreversible. Sarah knew all of this. She had calculated all of this in the time it took the gurney to travel from the bay doors to the central position. She was already calling out orders in the flat, carrying voice that trauma surgeons develop not from training, but from the specific experience of needing to be heard clearly in rooms where multiple simultaneous emergencies are generating competing noise. "I need the hyperosmolar therapy running in the next 90 seconds, she said, "and I need someone to tell me what his last documented intracranial pressure reading was from the field team." Field team didn't have ICP monitoring capability, the charge medic said from behind her. Best estimate based on symptom presentation. "Okay," she said, "then we go off presentation." "Kapoor, what are you seeing on the thoracic side?" "Hemo-pneumothorax, right side," Kapoor said, steady now, the steadiness of someone who had found his footing 20 minutes ago and was holding on to it. "Need to decompress before we can get clean imaging." "Do it," Hayes said from the left side of the table. "Walker, talk to me about the ICP management." "Modified lung concept," she said. "We're targeting a MAP of 70, not the standard 85. I know that's lower than you're comfortable with. It's going to look wrong on paper, and it's going to feel wrong to everyone in this room. Trust the numbers." Hayes said nothing for 3 full seconds. "MAP target 70, he told the anesthesiologist. "Document the deviation from standard protocol." "Already doing it," the anesthesiologist said. The next 4 minutes were the kind of 4 minutes that don't feel like 4 minutes. They feel like one continuous held breath with a series of precise, critical actions happening inside it. Kapoor decompressed the hemopneumothorax. The general's oxygen saturation, which had been declining with the particular slow inevitability of a problem that knows it's winning, stabilized and then, cautiously, began to improve. Sarah had the hyperosmolar therapy running and was tracking the pressure indicators on the monitoring equipment with the focus of someone reading a language that everyone else in the room only partially understood. "His pupils," she said suddenly. "Right pupil is sluggish. That's increased ICP despite the therapy." "How increased?" Hayes said. Enough that we need neurosurgery in the next 3 minutes, not 4, she said. Where is neurosurgery? 2 minutes out, Delgado said from the door. Dr. Reeves is coming from the East Wing. Get him here faster, Sarah said. Please, she added, because she was aware that Delgado was not someone who responded well to commands delivered without acknowledgement of the human being delivering them. And this was not the moment to create friction where there didn't need to be any. Delgado was already on the radio. Dr. Reeves arrived in 140 seconds, which was impressive. He was 57 years old, silver-haired, and had the particular kind of self-possession that comes from being genuinely excellent at something for a very long time. He also walked into Bay 1, assessed the situation in approximately 10 seconds, and then looked at Sarah with an expression she recognized immediately. It was the same expression Hayes had been wearing all day, the one that said, "Who is this, and why is she talking?" "Who's running TBI management?" he asked Hayes. "She is," Hayes said. Just those 2 words. The absence of any qualifier in those 2 words was, Sarah understood, the closest thing to a voucher that Hayes was capable of producing under current conditions. Reeves looked at Sarah. "Walk me through your protocol," he said. "We don't have time for the full version," she said. Short version. MAP 70, hyperosmolar therapy initiated, right pupil sluggish indicating elevated ICP. I believe we have a subdural component that wasn't visible on the pre-arrival imaging because the pre-arrival imaging was field expedient and incomplete. "That's a significant assumption," Reeves said. "It's not an assumption," she said. "It's a differential based on mechanism of injury, pupil response, and the trajectory of his pressure readings over the last 8 minutes. If I'm right and we don't act, he herniates within the next 20 to 30 minutes. If I'm wrong and we do act, we do a diagnostic procedure that rules out the subdural, and we lose maybe 12 minutes of operative time on the thoracic side." She looked at Reeves directly. "I know which risk I'm willing to take." Reeves looked at Hayes. Hayes was watching Sarah. Then Hayes said, "Do the diagnostic." Reeves considered this for exactly 2 seconds, which in that room felt like a very long time. Then he said, "Prep for burr hole diagnostic," to no one in particular, and the room reorganized itself with the efficiency of a team that had done this before, though not under these exact circumstances, and not with these exact people, and not with this patient. Sarah stepped back precisely enough to give Reeves the space he needed, and not 1 inch more. Hayes noticed this too. He was keeping a running internal account of things he was noticing about her, and he didn't particularly like what the account was adding up to, because it was adding up to something he was going to have to acknowledge eventually, and he was not ready to acknowledge it yet. The burr hole procedure took 11 minutes. 11 minutes during which the rest of the trauma bay operated with the specific, dense focus of people who understand that what they are doing right now is the kind of thing that gets remembered or doesn't get to be remembered at all, depending on how the next hour goes. Kapoor was finishing the thoracic repair. Hayes was managing the systemic resuscitation with the practiced efficiency of someone who had done it 1,000 times. Sarah was standing at the foot of the table watching every monitor simultaneously, which was a habit she had developed in the field where you learn to read the whole patient, not just your specific quadrant of responsibility, because in a forward position, there often wasn't anyone else covering the quadrants you weren't looking at. And then Reeves said, very quietly, in the tone of voice that neurosurgeons use when they have found what they were looking for, and the finding is simultaneously a problem and a relief. Subdural. She was right. The room absorbed this. Hayes absorbed it standing completely still, with a stillness that was different from his earlier stillness. That earlier stillness had been the stillness of assessment, of decision-making. This was something else. This was the stillness of a man recalculating. Sarah didn't say anything. This was not the moment for anything to be said. "Evacuating now," Reeves said, and proceeded to do exactly that with the calm precision of someone who is very, very good at what he does and knows it without needing anyone else to confirm it. 18 minutes later, the general's right pupil responded. It was a small thing, a physiological event measured in millimeters. But in Bay 1 it landed like a sound, like something physical had shifted in the air of the room. And Kapoor made a noise that wasn't quite a word. And Delgado pressed her lips together and looked at the ceiling for exactly 1 second in the way that people look at ceilings when they are trying to hold something in. And Hayes stood at the head of the table and looked at the monitor and said nothing at all. Sarah looked at the pupil response. She looked at the pressure numbers. She looked at the map reading, holding steady at 72. She let out a breath that she had been holding, she realized, for the better part of 20 minutes. He's stabilizing, she said, not triumphantly, just factually, the way she said everything. It was Delgado who broke first. She was a woman who had been in trauma nursing for 19 years, who had seen things in this hospital and in 2 previous deployments that had given her a specific kind of emotional armor that was necessary and functional, and sometimes, in rare moments, got bypassed entirely by something too direct to deflect. She looked at Sarah across the bay and said, "That was the right call." Just that. "Thank you," Sarah said. Hayes heard it. Kapoor heard it. The 2 nurses and the anesthesiologist and Dr. Reeves, who was closing and would be done in approximately 8 minutes, all heard it. Nobody commented on it directly, but the quality of the silence in the room changed. Hayes began his post-operative assessment documentation without speaking. He was a man who processed things internally, Sarah had already figured out, and the internal processing was going to take a while, and that was fine. She wasn't waiting for him. She had never been waiting for him. She moved to the monitoring station, updated the vitals log, flagged the protocol deviation for the formal incident report that would need to be filed by end of shift, and requested a neurology follow-up for the first available window after the general was cleared from acute recovery. Then she went to check on Specialist Webb, because he had been moved to post-surgical recovery 3 hours ago, and nobody had updated her on his status, and she was his attending, and that was her responsibility, regardless of what else was happening. Webb was awake. He was uncomfortable in the way that people are uncomfortable in post-surgical recovery when the anesthesia has worn off enough to allow consciousness, but not enough to dull the awareness of having been recently opened and repaired. He looked at Sarah when she came in with a specific, exhausted gratitude of someone who has been in pain for long enough that the simple presence of someone paying attention to that pain feels like relief. "How are we doing?" she asked. "Better," he said. "Honest answer this time, not soldier answer." He almost smiled. Almost. "Better," he said again, and this time she believed him. She reviewed his post-op numbers, adjusted one of the pain management orders, and was writing the updated note in his chart when he said, "Word travels fast in here." She looked up. "What kind of word?" she asked. "The kind about you," he said. "The general." She said nothing. "People talk," he said. "Nurses especially. They were saying you were the one who called the subdural." She wrote the last line of the chart note. "I was part of a team," she said. "That's not how they're telling it," he said. She capped the pen. "Get some sleep, specialist," she said. "Ma'am," he said. She turned around. It was the first time anyone in that hospital had called her that. She walked back out into the hallway. Hayes was waiting in the hallway. Not in the aggressive, territorial way he had occupied space earlier in the day. He was standing against the wall with his arms crossed and his head slightly down, which was, she was beginning to understand, what Hayes looked like when he was thinking hard about something he didn't want to think about. She stopped when she saw him. He looked up. "Walk with me," he said. It wasn't a question. She fell into step beside him, and they walked down the corridor toward the staff area at the far end of the East Wing, away from the active bays, away from the noise and the ongoing processing of the day's casualties, into the quieter institutional hum of a hospital at the beginning of its evening cycle. Hayes pushed open the door to the staff lounge. It was empty. He went to the coffee station, poured 2 cups without asking if she wanted one, set one in front of her, and stood on the other side of the counter. He drank from his cup. He set it down. He looked at her. "The Walter Reed Protocol," he said. "The classified file." "Yes," she said. "How long were you in the field?" 14 months, she said. "Officially, 14 months in a support advisory capacity." "And unofficially?" She held her coffee cup in both hands, long enough to know that the standard protocols were developed for conditions that don't exist in the field, long enough to start keeping data on what worked when the standard protocols didn't, long enough to write a report that a colonel at Walter Reed told me was impressive and then put in a classified file where nobody would have to do anything about it. Hayes was quiet for a moment. "That's why you came here," he said. It wasn't a question, but she answered it anyway. "This hospital sees the cases that the protocols fail," she said. "The complex concurrent presentations, the ones that fall between the standard categories. If there's any place where the data matters, it's here." Hayes looked at his coffee. "You could have led with that," he said. "You could have introduced yourself as the person who spent 14 months developing field protocols. You could have made that your opening." "Would it have changed how you treated me this morning?" she said. He was silent long enough that the silence was its own answer. "I don't think it would have," she said without heat. "I think I was going to have to prove it regardless, so I proved it." Hayes picked up his coffee cup again. He was quiet for a long time. Then he said with the specific difficulty of a man for whom this kind of admission does not come easily, "I owe you an apology for this morning. The wrist." The word landed between them with its full weight. He had grabbed her wrist in front of the team. He had shoved her back. It had not been acceptable. They both knew it. "You do," she said simply. He nodded. He didn't elaborate. He didn't justify. He just nodded, and the nod had in it enough acknowledgement that she decided to let it be sufficient for now. "Bay 3 is yours," he said. "Officially, not as a temporary assignment. You're the attending on Bay 3 effective tomorrow morning." She looked at him. "Why are you telling me this tonight?" she said. "Because tomorrow morning I'll be the department head again, and it'll come with conditions and paperwork and Kapoor standing there trying to decide whether to congratulate you," he said. "Tonight I'm just a surgeon who watched someone save a patient he couldn't have saved alone." He picked up his coffee. He walked toward the door. He stopped with his hand on the doorframe. Without turning around, he said, "The report at Walter Reed, the classified one. Do you have a copy?" "I have the unclassified summary," she said, "on my personal drive." "Put it on the department server before you go home tonight," he said. "I'll read it in the morning." He left. Sarah stood in the empty staff lounge and drank her cold coffee and thought about 14 months and how long it takes for the right room to hear something that has been said into wrong rooms for a very long time. She was on her way to the parking area, 2 minutes from the end of what had been, by any reasonable measure, one of the most significant 12-hour periods of her professional life, when her pager went off. She looked at the number. It was the ICU. She changed direction without stopping. The ICU duty nurse was a young man named Private First Class Garrett, who had the specific energy of someone who has just witnessed something unexpected and is not sure how to categorize it. He met her at the ICU entrance. "Dr. Walker," he said, "General Donovan is asking for you." She stopped. "He's conscious?" "Came around about 20 minutes ago," Garrett said. "Reeves cleared him for minimal verbal interaction. Low stimulation, short duration. But he's asking for you specifically." "He doesn't know me," she said. "He knows your name," Garrett said. Apparently it was the last thing he heard before he went under. Someone in the bay said it. She thought about the bay. She thought about Reeves saying she was right. She thought about the room hearing it. She walked into the ICU. The general was in the third bay from the left. He looked like what he was, a man who had survived something significant and was still in the early and precarious process of understanding that he had survived it. He was connected to monitoring equipment. He was pale. His eyes were open, though, and they were the clear, focused eyes of a man who was fully present in whatever degree of presence his current condition allowed. Sarah pulled a chair to his bedside and sat down, because she had learned a long time ago that bedside conversations with patients who were lying down went better when you were not standing over them. "General Donovan," she said, "I'm Dr. Walker. I'm glad you're awake." He looked at her for a moment. His voice, when it came, was rough and low, and carried in it the particular quality of someone working through significant discomfort with the practiced stoicism of a career military man. "You're the one they were arguing about," he said. "In the bay. I could hear it before I went under." "I'm sorry about that," she said. "Don't be," he said. "I've been in rooms where people argue about the right call for 38 years. I know what right sounds like." He was quiet for a moment. "Reeves told me," he said, "the subdural, the protocol." She said nothing. "He said the standard protocol would have killed me," the general said. She chose her words carefully. "The standard protocol was developed for a different presentation," she said. "Your case was complex. The team adapted." "You adapted," he said. She didn't argue with him. He was 4 stars, and he was 3 hours out of neurosurgery, and she was not going to spend his limited verbal window on modesty that was also, if she was honest with herself, not entirely accurate. "Yes," she said. He nodded, very slightly, in the way that people nod when something has been confirmed that they already knew. "What's your name again?" he said. "Walker," she said. "Dr. Sarah Walker." He closed his eyes. She thought he was drifting. Then he said, without opening them, "I'm going to remember that name." She sat with him for another 4 minutes until his breathing evened out into sleep. Then she stood, straightened her coat, returned the chair to its position, and walked out of the ICU. In the hallway, she stopped for a moment. She thought about Hayes and the apology that had cost him something. She thought about Kapoor and the bleeder at 9 o'clock, and the breath he had released afterward. She thought about Delgado and 2 words across a trauma bay. She thought about Webb calling her ma'am. She thought about a classified report sitting in a file at Walter Reed and what it might mean if it finally got read by people who could actually do something about it. She thought about all of the things that had happened in the last 12 hours, and she understood, not with satisfaction exactly, but with something quieter and more durable than satisfaction, that today had been the first day of something. She didn't know yet exactly what, but she could feel the shape of it beginning to form. The way you feel a tide turning, not by watching the water, but by standing in it and feeling the direction of the pull change underneath your feet. She walked to her car. She drove back to the apartment the base had assigned her, changed out of clothes that smelled like antiseptic, in 14 hours of sustained concentration, opened her laptop, located the unclassified summary of the Walter Reed protocol on her personal drive, uploaded it to the department server, tagged it for Hayes' attention, and closed the laptop. She did not sleep right away. She lay in the dark and listened to the bass settling around her, and thought about what Hayes had said. "Tonight I'm just a surgeon who watched someone save a patient he couldn't have saved alone." She thought about that for a long time. Then she closed her eyes. Tomorrow was going to be different. Not easier necessarily, not simple, but different. And she had learned over a long time and in hard places that different was usually where everything important began. She had uploaded the file at 11:47 the night before. Hayes read it by 6:15 the next morning. She knew this because when she arrived at the hospital at 6:49, 14 minutes earlier than her official start time, there was already a message on the department system from Hayes, time-stamped 6:22. It said 4 words, "My office, before rounds." She went to his office. He was standing at his desk, not sitting, with the printed summary in his hand, in the look of a man who had been awake for a while and had been thinking hard for most of it. He didn't offer her coffee. He didn't offer her a seat. He held up the summary and said, 81% survival rate in concurrent TBI and thoracic trauma. Across how many cases? 47, she said. Over 14 months. He set the paper down. And the remaining 19%? 3 of the 9 non-survivors had injuries that were non-survivable regardless of protocol, she said. 2 had delayed presentation to the surgical team. 1 had a coagulation disorder that wasn't identified in field triage. The remaining 3 are the honest failures. Cases where the protocol didn't perform, and I don't have a full explanation yet for why. He looked at her. You're including your own failures in the number, he said. It's not useful data if I don't, she said. Hayes picked up the paper again. He looked at it for a moment. Then he said, I want to run a department review. Formal case presentation. Your protocol against our current standard outcomes for the same case category. She understood what he was saying. That's going to take time, she said. And it's going to generate pushback from people who've been using the standard protocol for 15 years and don't want to hear that it might need revision. I know, he said. Do you want to run it or not? She didn't hesitate. Yes. Then be in the conference room at 1400, he said. I'll have Kapoor pull the last 3 years of case files matching the concurrent presentation category. He picked up his coffee cup. Rounds are in 20 minutes, he said. Go prep your bays. She was almost at the door when he said, without looking up from his desk, the 9 non-survivors, the 3 honest failures. Write those up separately, full narrative. What you tried, what failed, what you do differently. She turned. That's going to be uncomfortable reading, she said. It's supposed to be, he said. That's how you learn from it instead of just carrying it. She left his office and stood in the hallway for exactly 3 seconds longer than she needed to. Then she went to prep her bays. Rounds that morning had a different texture than they had the day before. Not dramatically different. Not the kind of different that announced itself. The kind that you feel in the small adjustments, the half-second pauses before someone speaks. The way eye contact gets redistributed in a room when the hierarchy has quietly shifted. Kapoor fell into step beside her in the hallway between Bay 2 and Bay 3 with the specific casualness of someone who has thought about what they want to say and has decided to deliver it as though they haven't. Heard about the general, he said. Word travels, she said, and thought about Webb saying the same thing. Reeves told Hayes this morning that the subdural call was the fastest correct differential he'd seen in a concurrent trauma presentation in 12 years, Kapoor said. She looked at him sideways. Did Reeves tell Hayes that, or did Reeves tell you that, and you're telling Hayes by telling me? Kapoor had the grace to look mildly caught. Both, he said, but mostly the second one. She almost smiled. Thank you, Kapoor, she said. I mean it. Priya, he said. You can call me Priya. She nodded. Priya, she said. He nodded too, and they walked into Bay 3 together. And that small exchange, that single first name, was the kind of thing that doesn't seem significant until you look back at it later and understand that it was the moment a professional relationship became something with more weight to it. Webb was awake and significantly more comfortable than he had been the previous afternoon. His color was better. His eyes were clearer. He sat up a little when Sarah came in, and she told him to lie back down with the flat authority of someone who was not issuing a suggestion. And he lay back down without argument, which told her the pain was genuinely better because yesterday he had been too uncomfortable to have the energy to comply. Numbers look good, she said, reviewing his chart. How's the mobility? Stiff, he said. Expected, she said. I want you on assisted movement this afternoon. Not a lot. Enough to start preventing adhesion at the repair site. When do I get out of here? He said. She looked at him. You just had abdominal surgery, she said. Your discharge timeline is not this week's conversation. I have a unit, he said. Your unit has other people in it, she said. Right now your unit is this bed. Take the week. He looked like he wanted to argue and decided against it, which was the correct decision. I heard about the general, he said. She capped the chart pen. You're about the 4th person this morning, she said. Does news always move this fast here? Faster, he said. Military hospital. Everybody knows everybody. And everybody knew the general. He paused. They're saying Hayes backed your call, he said. Backed it in the room, she said. That's the part that matters. He studied her for a moment with the specific, careful attention of someone who has spent years learning to read people quickly, because in his line of work, reading people quickly was sometimes the difference between a completed mission and a catastrophic one. You're not what I expected, he said. What did you expect? She said. I don't know, he said. Not someone who argues with Hayes and wins and then goes home and sleeps. I didn't sleep much, she said. He smiled at that, an actual, full smile, the first one she'd seen from him. Get some rest, specialist, she said, and went to her next patient. The conference room at 1400 was fuller than she had anticipated. She had expected Hayes, Kapoor, maybe Delgado. What she walked into was 8 people, including Reeves, including the hospital's chief medical officer, Colonel Patricia Marsh, including 2 senior surgeons she recognized by face but had not yet formally met, and including a man in uniform sitting at the far end of the table whose rank insignia indicated he was a colonel in the Army Medical Corps, and whose expression indicated he had been briefed on the meeting agenda and had thoughts about it. Hayes was at the front of the room. He looked at Sarah when she walked in with an expression that communicated approximately 3 things simultaneously. That he had not told her the CMO would be attending because he had not known himself, that he was aware this changed the nature of what was about to happen, and that he expected her to handle it without visible reaction. She handled it without visible reaction. She set her materials on the table, took the empty seat between Kapoor and Reeves, and looked at Colonel Marsh with the even professional attention of someone who had presented in difficult rooms before and understood that the room did not determine the validity of what was being presented. Marsh was 52, compact, with the direct physical economy of a career military officer and the particular sharp intelligence of a doctor who had reached administrative command without losing the clinical instincts that had gotten her there. She had read the unclassified summary. Sarah could tell by the way she held it, not like she was about to read it, but like she had already read it and had questions. Dr. Walker, Marsh said, I read the summary this morning. Before Dr. Hayes asked me to attend this meeting, I'll add. I read it because General Donovan's chief of staff contacted my office at 0700 requesting a full clinical report on the general's treatment. Sarah absorbed this information. That's standard protocol for a patient of his rank, she said. It is, Marsh said. What's less standard is that the chief of staff specifically asked that the report include the name and credentials of the physician who recommended the deviation from standard hemorrhagic shock protocol. The room was quiet. General Donovan asked him to ask us, Marsh said. Apparently, the general has a good memory for things he hears in trauma bays. The man in uniform at the end of the table, whose name badge read Colonel Sayers, cleared his throat with the specific diplomatic precision of someone managing the political temperature of a room. The general's office is also aware, he said, that the Walter Reed protocol summary originated with Dr. Walker's fieldwork. They're requesting a copy of the classified full report through official channels. Sarah looked at Sayers. The classified report is at Walter Reed, she said. I have the unclassified summary. We know, Sayers said. The channels are already moving. He paused. That's not a criticism, doctor. That's the opposite of a criticism. Hayes said from the front of the room, with the dry flatness of a man who is reclaiming the meeting he called. If we could run the case comparison before the bureaucracy formally catches up with us. Kapoor pulled up the case files. He had done good work with them. 3 years of concurrent TBI and thoracic trauma presentations at Landstuhl, sorted by outcome, mapped against the standard protocol parameters. 42 cases. Sarah looked at the outcomes column and understood immediately why Hayes had wanted her to see this. The survival rate in the comparable case category at Landstuhl, over the last 3 years was 63%. Against her field protocol's 81, an 18-point gap. Over 42 cases, that gap represented approximately 7 or 8 lives. Not statistical abstractions. 7 or 8 people who had not come home. She did not say this aloud. She didn't need to. Every person in that room who could do the arithmetic was doing it. The presentation ran for 50 minutes. It was not a smooth 50 minutes. It was 50 minutes of the kind of professional friction that happens when data challenges established practice, and the people whose practice is being challenged are smart enough to engage with the data seriously rather than dismiss it, and proud enough to push back hard on every point they could legitimately push back on. The 2 senior surgeons, whose names she had not yet learned, Doctors Fletcher and Okafor, were the sharpest critics. Fletcher was 60, trained at Duke, with a publication record that ran to 37 peer-reviewed papers, and a specific talent for identifying methodological weaknesses in any study he was presented with. He found 3 in the field protocol data. 2 of them were genuine weaknesses that Sarah acknowledged directly. One of them was based on a misreading of the case selection criteria that she corrected without heat, and watched him reconsider with the specific internal recalibration of a man who respects his own intelligence enough to update his position when the evidence requires it. Okafor was different. He was 46, Nigerian-born, trained in London and then at UCSF, and he was quiet in a way that was not passive. He waited until the formal presentation was finished, and then he asked one question. "Dr. Walker," he said, "the 3 honest failures you referenced in the summary, the cases where the protocol didn't perform and you don't have a full explanation, can you tell us about one of them?" She had written them up that morning, as Hayes had asked her to do. The writing had taken 2 hours and had been, as she had predicted, uncomfortable. She looked at Okafor. She understood what he was actually asking. He wasn't asking for the clinical details. He was asking whether she was the kind of doctor who could stand in a room full of colleagues and talk about the time the work went wrong. "Yes," she said, and she told them about the case, the specific one. The staff sergeant named Delray, who had come in 11 months into her deployment with a presentation that matched every parameter of the modified protocol, and who she had treated with full confidence in the protocol's applicability, and who had died 7 hours later from a coagulation cascade that the protocol's pressure management had contributed to rather than prevented. She told them the clinical details. She told them what she had thought at each decision point and why. She told them what the autopsy review had indicated about where the protocol had failed. And she told them what she had changed in the protocol design afterward as a result of it. She did not tell them how she had felt. That was not what they were here for. But the fact that she had changed the protocol afterward, that she had absorbed the failure and done something constructive with it rather than filing it away in the category of acceptable losses, that was the part that mattered for this room. And she could see from Okafor's expression that it was the part he had been checking for. "Thank you," he said. And the way he said it meant something more than courtesy. Colonel Marsh, who had been quiet for most of the presentation, spoke when Okafor finished. "Dr. Walker," she said, "I'm going to formally request the declassification of the full report through the Surgeon General's office. That process takes time. In the meantime, I'd like you to prepare a full clinical protocol document based on the summary for internal review." She looked at Hayes. "Dr. Hayes will oversee the review process." Hayes nodded once. "I'd also like you to present this to the full medical staff at next week's department meeting," Marsh said. "Not as a proposal, as a case study. What happened yesterday with General Donovan, what the data says, what the team decision process looked like. Let the staff form their own conclusions." Sarah said, "Yes, Colonel." Marsh gathered her papers and stood. "One more thing," she said. She looked directly at Sarah in the way that senior officers look at people when they are communicating something that is not being said aloud. The general's office called this morning. I told them you were a valuable member of this department. She paused. I wanted you to know that I said that before I attended this meeting. The conference room emptied gradually, in the way that rooms empty after significant meetings, with people stopping for short side conversations, and the specific reshuffling of professional relationships that happens when the power structure of a department has just been visibly, measurably adjusted. Fletcher stopped beside Sarah on his way out. He didn't stop long. He said, "The selection criteria point. Your methodology is tighter than mine suggested." I should have read the footnotes first. He didn't wait for a response. He walked out. She understood that this was, from Fletcher, the professional equivalent of a standing ovation. Okafor stopped longer. He sat on the edge of the table and looked at her with the particular thoughtful attention she was beginning to recognize as his characteristic mode. "The Delray case," he said, "the coagulation cascade. Have you considered whether a modified thromboelastography protocol at intake could have identified the predisposition before you initiated pressure management?" She looked at him. "Yes," she said. "I've been running through a potential integration for 8 months. I haven't had the case volume to validate it." "You do now," he said. He pulled a card from his coat pocket and set it on the table. "I've been working on a coagulation assessment integration for field presentations for the last 2 years. Different application. Some overlap with your work." She picked up the card. She looked at it. She looked at him. "You're not trying to take over my project," she said. It was direct. He took it as it was intended. "No," he said. "I'm suggesting a collaboration, equal contributors. Your field data, my coagulation methodology, combined validation. The combined work would be publishable in 12 months. He stood. "Think about it," he said. He walked out. Sarah sat at the conference table alone for a moment. She thought about the fact that 24 hours ago, she had been standing in this hospital's hallway with a chart in her hand and Hayes's contempt washing over her like something physical. She thought about the distance between that moment and this one, and about the fact that the distance had been covered not by time or luck, but by a succession of correct decisions made under pressure, and that the correct decisions had been possible because she had been carrying the preparation for them for 14 months in conditions that had not been comfortable or safe or officially recognized. And that this, all of this, the Okafor collaboration offer, the colonel's statement, the general's memory, Hayes's office door opening, that this was what preparation looked like when it finally found the right room. She picked up the card. She put it in her coat pocket. She went back to work. The general's first formal visitor arrived at 15:30. Sarah knew this because Garrett paged her from the ICU, not because the general needed medical attention, but because the visitor had specifically asked whether Dr. Walker was on the floor. The visitor was a woman named Brigadier General Linda Cho, the general's deputy commander, who arrived in full uniform with the focused efficiency of a senior officer conducting an assessment and the specific, barely contained emotion of a person who has just been told that someone they respect and depend on almost did not make it. She was standing at Donovan's bedside when Sarah came in. Donovan was significantly better. He was sitting up, which Reeves had cleared for short periods. His color was improved. His voice was stronger. He looked like a man who understood that he was still in the process of recovering, but who was already beginning to think past the recovery toward what came next, which was, Sarah had observed, a characteristic of a certain kind of person that was not unique to military command, but was certainly very common in it. He introduced Sarah to Cho with 2 words, the doctor, and then, looking at Cho with the specific precision of a man accustomed to communicating essential information in minimal time, he said, "She called a subdural that Reeves says would have killed me in 20 minutes if it had gone longer." Cho looked at Sarah with an expression that was several things at once: professional assessment, personal gratitude, institutional awareness of what the survival of a four-star Marine general meant in terms of continuity of command and operational impact, and all the things that attach to a person of that rank that had nothing to do with the person themselves and everything to do with the position. And underneath all of that, simpler and more direct, relief. "Dr. Walker," she said, "thank you." Sarah said what she always said. "The team did the work." "The team followed your call," Cho said. It was not a correction. It was an acknowledgement of a specific thing. "Yes," Sarah said, because she had already decided that this was not the moment for modesty. That was also not entirely accurate. Cho looked at Donovan. Some communication passed between them that had no words in it. Then Cho looked back at Sarah. "The general tells me there's a clinical protocol," she said, "developed in the field." "In development," Sarah said. "The data is strong, but it needs formal validation through an institutional review process." "How long does that take?" Cho asked. "At standard pace, 18 months to 2 years, Sarah said. At accelerated pace, with the right institutional support, 8 to 12 months. Cho held her gaze. "What kind of institutional support?" she said. "Access to case archives at multiple forward support hospitals," Sarah said. "A formal research designation that allows me to collect prospective data, and probably a conversation with whoever at Walter Reed decided a classified file was the appropriate destination for a clinical protocol that was actively saving lives." The silence after this statement lasted approximately 4 seconds. It was a very specific 4 seconds. Donovan made a sound that, from a man 3 hours out of neurosurgery, with a voice not fully recovered, was as close to a short laugh as his current physical state allowed. "She's not wrong," he said to Cho. Cho said, "No, she's not." She looked at Sarah with the full attention of someone filing information for specific future use. "I'll be in Germany for 48 hours, she said. "I'd like to schedule a formal briefing. You, me, and Colonel Marsh." "I'll make myself available," Sarah said. "Good," Cho said. Sarah did the evening check on Donovan's vitals, updated the monitoring orders, spoke briefly with the night ICU team about the parameters she wanted flagged, and walked out of the ICU into the hallway where Hayes was standing with his hands in his coat pockets. "How is he?" Hayes asked. "Better than this morning," she said. "Cho is here." "I saw her come in," he said. He was quiet for a moment. "She asked Marsh for your personnel file." Sarah stopped. "When?" 40 minutes ago, he said. "Marsh told me. Professional courtesy." He looked at her. "Cho runs the Medical Research Integration Division for Marine Forces Command in addition to her deputy role," he said. "I know," she said. He looked at her steadily. "Do you know what she does with personnel files she requests?" "I can make an educated guess," Sarah said. He held her gaze for a moment. "Don't undersell yourself in the briefing," he said. Just that. Then he put his hands back in his pockets and walked down the hallway. She stood there for a moment. The hallway was quiet around her in the particular way that hospital hallways get quiet in the early evening, when the acute surge has passed and the sustained hum of ongoing care settles in. She thought about Hayes telling her not to undersell herself. She thought about what it had cost him to say it. She thought about the distance a person has to travel, internally, in the space of 36 hours, to go from grabbing a colleague's wrist in a hallway to standing in an evening corridor and telling her not to sell herself short. It was not a small distance. She had no desire to diminish the ugliness of the morning before last. It had been ugly. It had been wrong. The wrist, the laughter, the sweetheart, all of it. But she was also capable of holding the ugliness of a thing and the growth beyond it in the same hand at the same time. And she thought that this capacity, this willingness to let people be more than the worst thing they had done in a moment of defensive cruelty, was one of the things that made her a good doctor, and possibly also, on her better days, a decent human being. She went back to Bay 3. She checked her remaining patients. She updated every chart. Then she sat at the workstation in Bay 3 for a moment, with her hands flat on the desk, feeling the quiet of a hospital in its night cycle settle around her. And she thought about tomorrow, in the briefing with Cho, and the protocol review, and the case presentation next week, and the collaboration card sitting in her coat pocket. And she thought about 14 months in a forward position, and a report in a classified file, and all the distance between where she had been and where she was standing right now. She thought about all of it. Then she stood up, straightened her coat, and went home. The briefing with Brigadier General Cho was scheduled for 900 hours. This morning she arrived early because she had not slept well, and lying in the dark thinking about the briefing was less productive than being at the hospital, where she could at least do something useful while thinking about the briefing. She did 2 bay checks. She reviewed the overnight vitals on all her active patients. She stopped by the ICU and reviewed the general's overnight monitoring log, which showed stable pressure readings in a normal sleep cycle and an ICP trending in exactly the direction she wanted it to trend. She wrote a brief update note and flagged it for Reeves. She went to the staff lounge and made coffee and stood at the counter drinking it and going through the briefing materials in her head for the 4th time. She had been doing this since approximately 3 in the morning. Not because she was underprepared, she was precisely prepared. She had the data, the protocol documentation, the case files, the outcome comparisons, all of it organized and ready. What she had been lying awake thinking about was not the content of the briefing, but the stakes of it. And she had a rule about the stakes of things, a rule she had made for herself early in her career and had maintained through residency and fellowship and 14 months in a forward position. She was allowed to think hard about the stakes exactly once, at the beginning, to make sure she understood the full weight of what she was walking into. After that, she put the stakes down, because carrying the stakes into the room with you was how you got in your own way. She put the stakes down at approximately 6:58. She finished her coffee. She went to work. Kapoor found her at 7:20 in Bay 3, where she was reviewing post-operative imaging on a patient who had come in overnight. A young Navy corpsman with a shrapnel injury to the upper left quadrant that the night team had managed well, and that Sarah was now signing off on with the clean satisfaction of reviewing work done correctly by people she was beginning to trust. Kapoor had his tablet and the specific expression of someone carrying information they are not sure is welcome. "Hayes asked me to tell you something," he said. "Why didn't Hayes tell me himself?" she said without looking up from the imaging. "Because he was walking away when he said it, and I think he didn't want to be present for your reaction," Kapoor said. She looked up at that. "What is it?" "Colonel Sayers called Hayes at 0700, Kapoor said. "The full classified report from Walter Reed has been formally requested through the Surgeon General's office. Expedited review. Hayes says it normally takes 6 to 8 weeks to process a declassification request at that level." He paused. "Sayers says this one has been assigned a 2-week turnaround." She set down the imaging tablet. She looked at Kapoor. 2 weeks, she said. "Donovan's office made a call," Kapoor said. "Apparently when a 4-star Marine general requests expedited declassification of a medical protocol report 3 days after that protocol saved his life, the paperwork moves faster than usual." Sarah absorbed this. "What was Hayes's reaction?" she said. Kapoor considered his answer carefully. He said, and I'm quoting directly here, that he was glad the timeline was moving and that you should not let it go to your head. She almost laughed. Not quite, but almost. "That's Hayes for congratulations," Kapoor said. "I'm starting to understand his vocabulary," she said. She picked up the imaging tablet again. "Tell him thank you." "He'll deny needing to be thanked," Kapoor said. "I know," she said. "Tell him anyway." The briefing was held in Colonel Marsh's formal conference room, which was a different room from the department conference room where the case comparison had been presented the day before. This room had a longer table and better chairs, and a quality of institutional seriousness that communicated without saying it that what happened in here had weight beyond the department level. Marsh was already seated when Sarah arrived at 8:57. Cho came in at 900 exactly, which Sarah was beginning to understand was a characteristic of Cho's rather than coincidence. The specific military precision of a person for whom punctuality was not courtesy, but discipline. She had a senior aide with her, a captain named Ruiz, who sat against the wall with a tablet, and the careful attentiveness of someone whose entire job in this room was to capture everything accurately. Cho opened without preamble. "Dr. Walker, I've read the unclassified summary twice. I've also read your personnel file, which Colonel Marsh provided, and I've spoken with Colonel Wynn at Walter Reed, who supervised your fellowship and who describes you as, and I'm quoting him, the most technically rigorous trauma fellow he has worked with in 22 years of fellowship supervision." Sarah said nothing to this. She had learned that when people quoted your supervisors at you, the correct response was to listen, not to deflect or qualify. "He also told me," Cho continued, "that he recommended you for a research designation at Walter Reed 18 months ago. A formal designation that would have given you access to the case archives and the institutional support to conduct a full validation study." Sarah looked at Cho. "I was told the designation had been approved," she said, "and then 3 weeks later I was told the position had been reallocated due to budgetary restructuring." Cho's expression did not change, but something around her eyes tightened by approximately 1 degree. "I'm aware of what you were told," she said. "I spoke with Nguyen for 40 minutes last night. The designation was not reallocated due to budgetary restructuring." The room went very quiet. "It was blocked," Cho said. "By whom?" Sarah said, and her voice was steady and flat and careful in the way that voices get when the person using them is managing a specific quality of anger that they have no intention of expressing in this room and at this moment. "A senior administrative officer who has since retired," Cho said. "The specifics of his reasoning are documented in an internal review that was conducted 8 months ago and is currently sitting in the same category of file as your clinical report." She paused. "The review found that the blocking was improper. It also found that the proper corrective action, which would have been to notify you and reopen the designation process, was not taken." Sarah sat with this for a moment. 14 months in a forward position. A report in a classified file. A designation that she had been told was budget, not obstruction. She had spent over a year believing that the system had failed her through indifference. What Cho was telling her was that it had failed her through something more deliberate than indifference, and that the failure had been known and the correction had not been made. She sat with this for a moment, and then she set it down. The way she had set down the stakes that morning, deliberately and completely. And she looked at Cho and said, "What happens now?" Cho looked at her with something that was close to respect and also close to relief. The relief of someone who has delivered a difficult truth and watched the recipient handle it with more steadiness than the situation required. "Now," Cho said, "we corrected." What correcting it looked like, in practical terms, was a formal research designation with Marine Forces Command Medical Research Integration, which Cho had the authority to assign directly without going through Walter Reed's administrative chain. It was not the designation that had been blocked 18 months ago. It was, Cho said with the specific, precise language of someone who understood exactly what they were offering, significantly better than that designation would have been. It included full access to the case archives of all forward support surgical facilities operating under Marine Forces Command. It included a research budget that Sarah would not have to apply for annually, but would be renewed automatically pending output milestones. It included a formal publication pathway through the Military Medicine Journal, with Cho's office as institutional sponsor, which meant peer review without the 18-month delay that civilian publication tracks typically carried for military medical research. And it included, Cho said, looking at Sarah with the full attention of someone making sure their words were landing correctly. A formal letter of acknowledgement from the Marine Commandant's office regarding the clinical work at Landstuhl. Sarah looked at her. A letter of acknowledgement, she said. Meaning what exactly? Meaning that the record is corrected, Cho said. The work you did in the field, the 14 months, the protocol development, the data, none of it was in your official file because it was classified and you were in a support advisory role that limited what could be documented. The letter acknowledges the specific contributions. It becomes part of your permanent record. She paused. It also, as a practical matter, makes it significantly more difficult for anyone to put your work in a classified file and leave it there again. Marsh, who had been quiet through most of the briefing, said, I'll be adding a department commendation to the file as well, for the work at Landstuhl on the day of General Donovan's admission, both the general's case and the broader day's casualty management. Sarah looked at Marsh. Then she looked at Cho. Then she looked at the table for approximately 2 seconds, and when she looked up, her expression was composed and professional. But her hands, which were flat on the table, pressed down just slightly harder than they needed to, and Cho noticed it and said nothing about it because she was a person who understood that composure is not the same as the absence of feeling, and that sometimes the most meaningful things are visible only in the small pressures. One more thing, Cho said. The general wants to see you before he's transferred to Bethesda. He's being moved tomorrow morning. I'll be in the ICU tonight for his evening check, Sarah said. He knows, Cho said. He asked me to tell you he'll be awake. Hayes was in the hallway outside the conference room when Sarah came out. She was beginning to wonder if Hayes had a specific talent for appearing in hallways at significant moments, or whether it was simply that the hallway was where most significant things happened in a hospital, and Hayes, being someone who moved through this hospital constantly, inevitably intersected with those moments. He looked at her face when she came out and read it the way people read faces when they have been working alongside someone long enough to understand what that person's face says, even when that person is being careful about what their face says. Good meeting? He said. Yes, she said. Productive. He nodded. He fell into step beside her and they walked down the main corridor. He was quiet for a moment, which with Hayes meant he was working up to something. Fletcher came to me this morning, he said. She waited. He wants to co-author the protocol validation study, Hayes said. With you. Specifically with you. He said, and again, I'm quoting, that your methodology is the tightest he's seen in a field-developed protocol, and he doesn't want to miss the publication. She thought about Fletcher at the conference table, pushing back on every point he could legitimately push back on, and conceding the ones he couldn't. She thought about what it meant that he had gone to Hayes rather than coming to her directly, and about what that said about the layered institutional social structure of a department like this one, and about the fact that it was changing, that structure, incrementally and in the specific ways that structures change when the evidence becomes too clear to route around. Tell him I'll meet with him this week, she said. You can tell him yourself, Hayes said. He's in Bay 4. She almost stopped walking. You set that up, she said. I told him you'd probably be walking past Bay 4 in the next 10 minutes, Hayes said. Whether you stop is your decision. She looked at him sideways. That's remarkably maneuvering of you for someone who spent yesterday morning telling me I wasn't qualified to make independent surgical decisions. Hayes was quiet for a beat. I was wrong about that, he said, simply. No qualification, no surrounding context to soften it. Just the 4 words delivered in the flat, honest voice of a man who had decided that a thing needed to be said and was saying it. She held his gaze for a moment. I know, she said, and the 2 words meant, I accept it. They meant, it's noted and it doesn't need to be said again. They meant, we can move forward from here. Hayes gave the single nod that was his characteristic receipt of acknowledgement. They walked past Bay 4. Sarah stopped. Dr. Fletcher, she said through the bay door. Fletcher looked up from his chart. Dr. Walker, he said, Hayes says you want to talk about the validation study. I do, he said. Are you free at 1600? I'll be free at 1600, she said. She walked on. Behind her, she heard Fletcher return to his chart, and Hayes continued down the corridor in the opposite direction, and the hospital moved around her with its continuous hum of managed urgency. And she thought about the research designation and the letter from the commandant's office, and Fletcher wanting to co-author, and Okafor's card in her coat pocket. And she thought about the specific velocity with which things can change when the right pressure is applied, in the right place at the right moment. And she thought, this is what 48 hours looks like when you don't leave the room. Specialist Webb was being moved out of surgical recovery and into a standard ward bed that afternoon, which was ahead of the schedule Sarah had outlined 2 days ago, but consistent with his recovery trajectory and his specific brand of determined physical cooperation with the healing process, which she suspected was less about comfort and more about wanting to be ambulatory enough to feel like a soldier again, rather than a patient. She stopped by during the transition. He was sitting on the edge of the bed while a corpsman helped him with the transfer, and he looked up when she came in with the expression of someone caught doing something they know their doctor is going to comment on. I know, he said. You're going to tell me to take it slow. I'm going to tell you to take it slow, she confirmed. But your numbers are good, and the repair is holding, so taking it slow from a slightly more independent location is acceptable. He looked at her with something in his expression that was different from the careful soldier reading she had seen from him over the past 2 days. Something more open. Can I ask you something? He said. She pulled the chair to his bedside and sat. Go ahead, she said. The first day, he said. Hayes, in the hallway. The thing with your wrist. She looked at him steadily. What about it? How did you not walk out? He said. I mean that genuinely. I've served under commanders who would have broken a man for less. In front of a team like that, in front of patients. How did you stay? She thought about how to answer this. She thought about 22 in the surgical attending and 6 hours on a synthetic tissue pad and counting to 10 and converting heat into fuel. She thought about 14 months in a classified file and an improperly blocked designation and all the versions of the same basic structural dismissal she had absorbed over a decade of being the youngest person in every room she was ever qualified to be in. And the female person and the person who came from a state school before Johns Hopkins, and whose parents were not doctors, and who did not have the particular social fluency that comes from having grown up in rooms where medicine was a family legacy rather than a chosen direction. She thought about all of it. Then she said, because walking out would have meant he was right. Webb was quiet for a moment. That's it? He said. That's it, she said. He nodded slowly, the nod of someone integrating something into a framework they already had, adding a new data point to a structure that had been built from years of making the harder choice in the harder moment. I'm going to tell that to my guys, he said, when I get back. Take the week first, she said. She stood. She straightened his chart on the bedside table. Webb, she said. He looked up. Marcus, she said. You can call me Marcus, he said. She smiled. An actual, full smile, the kind she didn't give out cheaply. Take the week, Marcus, she said. He smiled back. Yes, ma'am, he said. She met with Fletcher at 1600, and it lasted 40 minutes, and it was the most technically engaged conversation she had had in a professional context since a 3-hour debrief with a colonel at Walter Reed 18 months ago that had ended with her report going into a classified file. Fletcher was, stripped of the institutional self-protection that the conference room had required him to maintain, an exceptionally precise thinker who had a genuine gift for identifying the structural vulnerabilities in any research design and an equally genuine gift for suggesting solutions to those vulnerabilities that were elegant rather than merely corrective. By the end of 40 minutes, they had the framework for a three-stage validation study that was, Sarah thought, substantially stronger than what she had been carrying alone. She did not say this aloud. She made a note of it internally and added it to the growing account she was keeping of what the last 48 hours had demonstrated about what becomes possible when the institutional resistance to a thing finally lifts. She added Okafor's card to the co-author conversation before she left the bay. Fletcher had not known about the coagulation assessment integration work. When she outlined it for him, briefly but with enough precision for him to grasp the implications, he was quiet for a moment in the way that people are quiet when they have just seen something that expands the scope of what they thought they were working on. That changes the design, he said. Yes, she said. For the better, he said. Yes, she said. He wrote Okafor's name on the framework document without being asked. She noticed this and chose to find it encouraging. She was in the ICU at 19:30 for the general's evening check. The numbers were excellent. The pressure readings were stable and clean. The neurological indicators that Reeves had been tracking had been moving in the right direction for 36 consecutive hours, which Reeves had told her that morning was as good a post-operative trajectory as he had seen in a concurrent TBI and thoracic trauma case in his career. She updated the monitoring orders, spoke with the night team, and then stood for a moment at the foot of the general's bed because he was awake, and he was looking at her. Cho briefed me, he said. His voice was stronger than it had been the night before. Not fully recovered, but directionally recovered, which was the kind of thing you felt before you could fully hear it. On the briefing, he clarified, the designation, the letter. She said, I know, she told me she would. He was quiet for a moment. The blocked designation, he said. She met his eyes. That should not have happened, he said. Simply and directly, the way he said everything. No, she said, it shouldn't have. I made a call about the 2-week declassification timeline, he said. I know, she said. Thank you. Don't thank me, he said. Thank the protocol. It made the argument better than I could have. He looked at her for a moment with the specific, clear attention of a man who had spent 38 years assessing people quickly and had developed a particular quality of perception as a result. I'm going to Bethesda tomorrow morning, he said. I know, she said. When I'm cleared for duty, he said, I'm going back to my post. There are decisions made at my level that affect the resources available to forward surgical teams. The equipment, the protocols, the training. He paused. I've been making those decisions for 3 years based on information that was less complete than it should have been. He held her gaze. The validation study. When it's done, I want to see it. You'll see it, she said. I'll make sure of it. He nodded. He closed his eyes. She adjusted the monitoring settings and began to write the evening note. She was halfway through it when his voice came again, quieter now, with the specific quality of someone speaking from the edge of sleep, where things sometimes come out more directly than they would in full wakefulness. Walker, he said. Yes, sir, she said. That word I used, he said, when Garrett told me your name, the one that ended up traveling through this hospital. She waited. I meant it, he said. I know, sir, she said. I know. She finished the note. She filed it. She walked out of the ICU into the quiet of the evening hospital, and she stood in the hallway for a moment with the nighttime hum of the building around her, and she thought about everything that word carried with it now. Not just the general's voice saying it, but Cho's briefing and Fletcher's framework document and Okafor's card and Hayes's 4 words that morning and Marsh's commendation and Webb's full smile and the 2-week declassification timeline and a designated research position that was, finally, exactly what the work had always deserved. She thought about all of it. Then she pulled out her phone and called the one person she always called when something important happened. Her mother picked up on the second ring. Sarah? Her mother said. Hey, Mom, she said. Her voice was steady. Her hands were completely still. "I just wanted to call," she said. "I had a good day." She did not explain what a good day meant in this context. Her mother, who had raised her and had watched her study and had driven her to her first surgical rotation at 5:30 in the morning and had listened to every version of every door that had been closed in front of her for the last decade, did not need the explanation. "Tell me," her mother said. And Sarah, standing in the quiet hallway of a military hospital in Germany, with the most important 48 hours of her professional life behind her, and everything that came next beginning to take shape in front of her, told her. The general left Landstuhl at 0700 the next morning. Sarah was not there for the transfer, not because she didn't want to be, but because Hayes had put her on the first surgical case of the day at 6:45. A complex abdominal repair on a Marine corporal who had come in overnight with blast injury complications that the night team had stabilized and that needed definitive surgical management before anything else happened. This was, Sarah understood, exactly the right priority. The work came first. It had always come first. The general understood this better than anyone, and if he had any expectation of a formal farewell, the monitoring note she had filed the previous night and the updated care transfer documentation she had completed for the Bethesda team were the version of farewell that a trauma surgeon could actually offer. She was scrubbing out from the abdominal repair at 8:22 when Garrett found her at the scrub sink with the slightly breathless quality of someone who had been moving quickly through the hospital looking for a specific person. "He asked me to give you this," Garrett said. He held out a folded piece of paper. She looked at it. Then she took it and opened it with one still damp hand. The handwriting was precise and slightly formal in the way of someone who had written countless official documents and could not fully separate personal correspondence from the habits of command. It said, "Walker, the protocol works. Make sure everyone knows it. Donovan." She read it twice. She folded it and put it in her coat pocket next to Okafor's card. She finished drying her hands. She went to her next patient. 2 weeks passed. They were not quiet weeks. They were the kind of weeks that happen when something has been set in motion and the motion is still accelerating. When every day brings a new iteration of a thing that is becoming more real and more specific and more consequential than the day before. The declassification came through on day 11. 3 days ahead of the 2-week timeline that Donovan's office had assigned. Hayes brought the notification to Sarah directly, which was a thing he would not have done 5 weeks ago, but which he did now as a matter of course, walking into Bay 3 with the printed notification and setting it on the workstation without ceremony. "Walter Reed cleared the full report," he said. "It's in the department system as of this morning." She looked at the notification. 47 cases, 14 months, the full clinical data, the full protocol parameters, the full outcome analysis, now fully accessible to every physician in the department and, through the research designation Cho had assigned, to every forward support surgical facility in Marine Forces Command. "Fletcher and Okafor have already requested access," Hayes said. "I know," she said. "I got their messages at 6:30. "There were also 2 messages from physicians at other commands," he said. "Army and Air Force. They heard about the general's case to the Medical Corps network." She looked at him. "How did they hear about the case specifically?" "Sayers," Hayes said flatly. "Colonel Sayers has a wide professional network and apparently a specific philosophy about information that saves lives not being the exclusive property of one command." He said this with the tone of a man who had opinions about Sayers's approach to information sharing, but had decided that in this specific instance, those opinions were less important than the outcome. She looked at him for a moment. "Are you angry about it?" she asked. He considered this with the genuine consideration he brought to questions he took seriously. "No," he said. "I'm irritated by the process. The outcome is correct." She nodded. "The department presentation is Friday," she said. "I know," he said. "I set the agenda." He picked up the notification copy. "Don't be late," he said. He walked out of Bay 3. She turned back to her patient. Kapoor appeared in the bay doorway approximately 40 seconds after Hayes left, which suggested he had been waiting for Hayes to finish and had not wanted to be in the room for whatever Hayes's version of encouragement looked like. "Army and Air Force," he said. "Already." "Word travels," she said. He grinned. "Still want me to pull additional case files for the presentation?" "Yes," she said. 5 years, not 3. And include the concurrent presentations that were coded differently in the system. The ones that were categorized as primary thoracic without the TBI notation. "I think we've been undercounting the case category." He stopped. "Undercounting by how much?" "Potentially 30%, she said. He was quiet for a moment. "That changes the comparison numbers," he said. "Yes," she said. "It makes the gap larger." He looked at her with the specific expression of someone integrating a piece of information that is simultaneously disturbing and clarifying. "Go pull the files," she said gently. He went. The department presentation on Friday drew 41 people, which was 14 more than had attended any department meeting at Landstuhl in the previous 2 years, according to Delgado, who had attended all of them and had a reliable memory for that kind of data. People came from outside the trauma department, people from orthopedics and neurology and the anesthesiology team, and 2 physicians from the administrative medical staff who did not typically attend department clinical presentations, but who had clearly received specific information about what this one contained. Sarah stood at the front of the room and looked at 41 people and felt nothing that resembled stage fright. She had felt the stakes. She had set them down. She was here to present the work. She started with the cases, not with the protocol, not with the methodology, not with the outcome data, with the cases, specific patients, specific presentations, specific moments inside specific surgical procedures, where the standard protocol had created a constraint and the modified protocol had resolved it. She had changed the names. She had kept everything else. She told them about a 24-year-old Army specialist in a high-altitude engagement zone whose blood pressure had been managed to standard parameters by a field team and who had arrived at the forward surgical position already showing signs of herniation because the standard MAP target had been 30 points too high for his concurrent TBI component. She told them about what had happened when she had dropped the target and initiated hyperosmolar therapy. She told them about the pupil response, 8 minutes in, that had told her it was working. She told them about him walking out of the medical facility 6 weeks later. The room was very quiet. She told them about Delray. She told it exactly as she had written it for Hayes, without flinching and without the passive voice and without any of the rhetorical distancing that people use when they talk about the cases that went wrong. She told them what she had missed and what she had changed and why the change mattered. The quiet in the room during the Delray case was a different quality of quiet from the quiet during the success cases. It was the quiet of people who have been in their own version of that room, who have had their own version of that patient, who carry their own version of that weight, and who are watching someone else carry theirs in public and thinking about what it costs and whether they could do the same. Fletcher said nothing during the presentation. He watched and listened with the focused attention of a man who had already engaged with the material deeply and was now processing the difference between reading data and watching the person who had generated it stand in a room and own every piece of it. When Sarah finished and opened the floor for questions, Fletcher was the first to speak. "The case selection for the validation study," he said, "Kapoor's revised coding analysis. If the concurrent presentation category has been undercounted by 30%, we need to go back 5 years at minimum, possibly 7. "I know," Sarah said. "I want to go back 7. He nodded. "7 it is," he said, like it was already decided. Because it was. Okafor asked 3 questions that were so precisely calibrated to the specific intersections between her protocol and his coagulation integration work that answering them felt less like a Q&A and more like the opening movements of a collaboration that had already begun. By the 3rd question, the rest of the room had understood that something was being built in front of them in real time and had gone slightly more still in the specific way that people go still when they are watching something being created and do not want to interrupt it. Hayes asked no questions. He sat at the back of the room through the entire presentation with his arms crossed and his expression unreadable. When the session ended and people began moving towards Sarah with the specific post-presentation energy of people who have heard something that has changed how they think about something and want to engage further, Hayes stood, gathered his notebook, and walked to the door. He stopped there. He turned and looked at Sarah across the full length of the room, across the 40 people now moving around her with their questions and their responses and their beginning of new professional connections, and he gave the single nod. The nod that meant correct. The nod that, from Hayes, contained everything he was not going to say in a room full of 40 people, and everything that did not need to be said because she already knew it. She held his gaze for exactly 1 second, then she turned to answer the next question. Webb was discharged on the Friday of the 2nd week. He came to find her before he left, which she had not expected but which she found, when he appeared in the Bay 3 doorway with his duffel over his shoulder and his color fully restored and his posture, the return posture of someone who had reclaimed the physical self-possession of a soldier. She found it meant something to her in a way that was not clinical. Discharge paperwork is signed, he said. Follow-up instructions, she said. Read them twice, he said. Correct answer, she said. He shifted the duffel slightly. He looked at her with a direct and unguarded attention that she had come to understand was simply how he looked at people he respected. I heard about the presentation, he said. News travels, she said. Still, he said, 41 people. 42, she said. Kapoor was sitting on the windowsill. He counts. Webb smiled. I'm going back to my unit next week, he said. Light duty for the first month, she said. The paperwork says so. I know what the paperwork says, he said. He paused. I'm going to tell them, he said, my guys, about you, about the call you made on the general, about the protocol, about what you said to me when I asked why you didn't walk out. He said it plainly, without ornamentation, the way soldiers say things that matter to them. She looked at him for a moment. Tell them the part about the protocol, she said. The part where one doctor with 14 months of field data and a classified report that nobody read almost didn't get the chance to use any of it in a room that actually mattered. He held her gaze. I'll tell them that part too, he said. He put out his hand. She shook it. His grip was firm and brief and honest. Take care of yourself, specialist, she said. Marcus, he said. Take care of yourself, Marcus, she said. He nodded once. He walked out of Bay 3 with the particular walk of someone who knows where they are going and is ready to go there. She watched him until he turned the corner. Then she went back to work. The call from Bethesda came 6 days later, not from Donovan's office, from Donovan directly, which she knew before she answered, because the caller identification showed a Maryland area code, and Garrett had mentioned 2 days ago that the general had been transferred to outpatient status, which meant he was in a room with a phone he could use without a nurse approving the call first. She answered on the second ring. Walker, she said. Doctor, he said. His voice was fully recovered, strong and precise, and carrying in it the specific quality of command authority that apparently returned before everything else did. General, she said, how are you feeling? Better than I should be, he said. According to Reeves, who called me yesterday to review my outpatient protocols and told me my recovery trajectory was the best argument he'd ever seen for the modified pressure management approach. She held the phone. I'm glad to hear it, she said. Cho tells me the validation study is moving, he said. Fletcher and Okafor came on board, she said. 7-year case file review across Landstuhl, plus 2 Army facilities that requested access after the department presentation. We're targeting a first-stage data submission in 4 months. He was quiet for a moment. 4 months, he said. That's fast. We have good people, she said. He made a sound of genuine satisfaction. I have a meeting next week with the Surgeon General's office, he said. Joint session, all services. They review resource allocation for forward surgical support on a 6-month cycle. I've asked to add the protocol validation work to the agenda. She was very still. As a presentation? She said. As a funding discussion, he said. There's a difference between a research designation from Cho's office and a joint services allocation. The second one moves the work from one command's resource base to everyone's. She understood exactly what he was saying. That's a significant acceleration, she said. Yes, he said, it is. He paused. I want you on a call with my office before the meeting. Background briefing. You, me, and Cho. I'll be on the call, she said. Good, he said. He was quiet for a moment. Then, in the slightly lower register of someone saying something that is separate from the official business of the call. Walker. Yes, sir, she said. That note I left you, he said. The paper Garrett gave you. I have it, she said. Good, he said again. Keep it. He hung up. She set the phone down. She looked at Bay 3 around her, at the workstation and the monitoring equipment and the chart rack and all the institutional fixtures of a trauma bay that was now, officially, hers. She thought about a joint services funding discussion. She thought about the Surgeon General's office. She thought about 7 years of case files in 4 months and Fletcher's methodological precision and Okafor's coagulation integration and Kapoor pulling files at 6:30 in the morning with the focused energy of someone who understood what the data meant and wanted to be part of the work of proving it. She thought about all of it. She looked at her hands. She went to her next patient. Hayes called her into his office on the last day of her first month at Landstuhl. She had been keeping an informal count of the number of times she had been in his office and the character of each visit, not out of any analytical purpose, but because the progression was, she thought, one of the more interesting things she had observed in a professional context in a long time. The first time had been his demand before rounds, the day after the general's surgery. That had been about the protocol summary. The second time had been the late evening conversation over cold coffee when he had offered her Bay 3 and told her to put the file on the department server. That had been something harder to categorize. The beginning of a recalibration that neither of them had named. Every subsequent visit had been incrementally more normal in the specific sense that conversations between two physicians who have worked alongside each other and developed a professional respect tend to become more normal when the respect is mutual and earned and no longer contested. This visit was different from all the previous ones, and she understood this before she sat down because Hayes was sitting behind his desk rather than standing at it, which was unusual, and because he had a personnel form in front of him with the specific layout of an official department recommendation. He looked at her when she came in and said, "Sit down." She sat. He pushed the form across the desk toward her. She looked at it. It was a formal recommendation for appointment to senior attending trauma surgeon with department research lead designation, effective the 1st of the following month. Her name was at the top. His signature was at the bottom. He had already signed it. "You're not going to ask me if I want the position," she said. "Do you want the position?" he said. "Yes," she said. "Then I didn't need to ask," he said. She looked at the form. "The research lead designation," she said. "That's a new title." "I created it," he said. "Marsh approved it this morning. It formalizes your role in the validation study as department principal investigator with full institutional backing. It also means that any request for your involvement in joint services research comes through this department officially, not through informal channels. She understood exactly what this meant. It meant that the next time someone tried to route her work into a classified file and leave it there was an institutional structure specifically designed to prevent that from happening. He had built the structure. He had gone to Marsh and built it and gotten it approved before telling her it existed. Hayes, she said. He looked at her with a flat directness that was simply how he engaged with things he had decided about. When I grabbed your wrist, he said, on the first day, she waited. That has not left me, he said. I know, she said. It shouldn't, he said. No, she said. It shouldn't. He was quiet for a moment. I have been practicing medicine for 26 years, he said. In that time, I have been wrong about clinical judgments 17 times by my own count, and I have updated my practice accordingly for each one. I have been wrong about people fewer times, but the times I have been wrong about people have cost more. He looked at her with the full weight of a man who had been sitting with something difficult for 30 days and was now setting it down in front of another person rather than continuing to carry it alone. You were the worst version of that, he said. The first day, what I did and what I said and what I allowed to happen in that hallway, that was the worst version. Yes, she said, it was. He nodded. He picked up a pen. He initialed the bottom corner of the form, the final authorization point. I won't do it again, he said, not as a promise to her, as a statement about himself, about who he intended to be going forward, and what this month had clarified for him about the distance between who he had been and who that was. She picked up the form. She looked at it for a moment. Neither will I, she said. He looked at her. Walk away, she clarified. I never will. Whatever room I'm in, whatever version of the first day someone decides to give me. He held her gaze for a long, steady moment. I know, he said, and the two words meant the same thing hers had meant to him 4 weeks ago. They meant, noted. They meant, I believe it. They meant, we move forward from here. The joint services call with Donovan and Cho happened on a Tuesday morning at 800 hours. Sarah was in her office, which was a thing she now had, a small room with a window and a desk, and a department server connection, and her name on a placard outside the door that Kapoor had photographed and sent to her with a single line of text that said, about time. She had Hayes on standby at his desk, available if the conversation required department-level confirmation of the research infrastructure. She had the full validation study framework document open on her screen. She had Okafor's most recent integration report and Fletcher's revised case selection analysis and the 4-month data submission timeline with its specific milestones laid out in the precise sequential logic of people who understood that a thing being possible and a thing being done on schedule were related but not identical propositions, and that the schedule required as much care as the science. Donovan opened the call at 800 exactly. Cho was on the line from her office. There was a third voice that Sarah had not been told to expect, a calm and direct voice that introduced itself as Rear Admiral Patricia Vance, Deputy Surgeon General for Research Integration, Joint Medical Command. Sarah absorbed this additional information without visible reaction. She was, by this point in her professional life, accustomed to rooms being larger than she was told they would be. She had learned to size up the larger room quickly and adjust accordingly without letting the adjustment show. Dr. Walker, Admiral Vance said, I've read the unclassified protocol summary and the department case comparison data. I've also read the full classified report, which was on my desk the morning after it was declassified. Yes, ma'am, Sarah said. The joint services meeting is next week, Vance said. I'll be presenting the research allocation proposal on General Donovan's agenda. Before I do that, I want to ask you directly, what do you need to complete the validation study at the highest possible standard? Sarah had thought about this question. She had thought about it specifically in the specific way she thought about clinical problems, which was to identify the constraints first, then the resources required to remove them, then the realistic path from current state to desired outcome. She had her answer ready. She gave it. She was precise and she was complete, and she did not ask for anything she couldn't justify with data, and she did not under-ask out of the instinct to seem low maintenance that had been trained into her by a decade of being the person in the room that institutional structures were not originally designed to support. Hayes would have told her not to undersell. She didn't. She told Vance exactly what the work needed to be done at the highest standard. Vance listened. She said, "I can authorize 70% of that from existing research allocation before the meeting. The remaining 30% is agenda dependent. But I want you to hear me say that the agenda is not a formality. The data makes the argument." "I know," Sarah said. "The data has always made the argument," she said. "It just needed the right room." Vance was quiet for a moment. Then she said, "General Donovan tells me you said something on your first day at Landstuhl when Hayes took you off a case in front of the team. You said, 'You just made the biggest mistake of your career.'" Sarah said nothing. "He thinks that was the moment he understood who he was dealing with," Vance said. "For the record," Sarah said, "I said it because it was true, not because it was dramatic." Vance said, "I know. That's exactly why he remembered it." Donovan's voice came on the line, brief and direct, the way it always was. "Walker." "Sir," she said. "The protocol works," he said. The same words from the note, delivered now in the full presence of a rear admiral and a brigadier general, and the institutional weight of a joint services research allocation discussion. "Make sure everyone knows it." She looked at her name on the door placard through the office window. She looked at Okafor's card and the folded note from Donovan, sitting side by side at the corner of her desk. She looked at the 4-month timeline and the 7 years of case files and everything that the next year of her life was going to be built from. "Yes, sir," she said. "I intend to." The validation study published in 14 months. It was the fastest peer-reviewed publication in military medicine's history for a multi-site trauma protocol study. The survival rate data held across 109 cases at 5 facilities. The 18-point gap held. The coagulation integration that Okafor had brought to the collaboration closed 2 of the 3 honest failure categories that Sarah had carried for over a year. The third remained open, a problem not yet solved, documented transparently in the study's limitations section, because that was how you built work that was worth building. The protocol was formally adopted by 3 service branches within 8 months of publication. Hayes presented it at the department's annual clinical review and called it, in front of 63 people, the most significant advancement in concurrent trauma management protocol he had seen in his career. He did not qualify the statement. He did not add context to it. He said it plainly, and he meant it. And everyone in the room who had been there for the first day understood exactly what that statement cost him and valued it accordingly. Kapoor made senior resident the month the study published. He told Sarah he was going to apply for a trauma fellowship at Walter Reed. She wrote his recommendation herself. She spent 45 minutes on it. She made sure it was the kind of recommendation that opened doors rather than merely describing the person standing in front of them. The note from General Donovan stayed in Sarah Walker's coat pocket through every shift for the remaining time she spent at Landstuhl, and every shift she spent after that, in the places the work eventually took her. Through every new room and every new version of the first day, and every moment where the choice was between walking out and staying, improving what she already knew to be true. The paper got soft and worn at the folds from being carried and occasionally taken out and read and put back. She never framed it. She never filed it. She kept it in her pocket because that was where it belonged. Because a thing you carry close is a thing you can feel when you need to remember why you stayed. She stayed. She always stayed. And everything that came from the staying proved, in the end, that she had been right to.